So, to manage 𝗠𝗏𝗏𝗏𝗏 Academy, this is a Vaginal Surgery Masterclass series, managing intraoperative bleeding during the vaginal anesthesia. So, number one is recognition, then prevention, and then control. The stakes why hemostasis control matters. 3.1% patients in the way the rate of major hemorrhagic events reported during vaginal anesthesia. 215 to 287 ml is a median intraoperative blood loss for vaginal anesthesia. But if it is more than 400 ml, EBL threshold linked to higher transfusion, reoperation, and a complication risk. So most intraoperative hemorrhage during vaginal hysterectomy is preventable with disciplined pedicle technique, not rescued after the fact. So the foundation is vascular anatomy at each step, uterosacral cardinal ligament complex, first pedicle taken, carries descending cervical and vaginal branches of the uterine artery, uterine vessels, artery and vein, highest flow pedicle in the operation, the single most common source of major hemorrhage. Broad ligament, utero-ovarian or 𝗕𝗏𝗏𝗏𝗏𝗏 pedicles, then ovarian vessels and the utero-ovarian vessels anastomosis is there, and they retracts rapidly if it's not secured there. Then vaginal artery branches, that's a lateral fornix. Then the frequent source of vault and curve bleeding, both intra and postoperatively. So preoperative assessment is important for the risk factors. Know before you cut a large fibroid uterus. There is a high vascularity, longer operative time. Limited uterine descent, harder pedicle access in non-descent cases. Previous pelvic surgery or additions, younger the age, more vascular the pelvis. Coagulopathy and anticoagulant use if this patient is being taken. And the prolonged operative time is more than 3 hours. You should be worried. These are the one of the very, very important point. And same thing if the specimen is weight is more than 250 grams. So before the incision, prevention starts preoperatively, optimize hemoglobin, and correct any coagulopathy in adults. Counsel and consent for possible transfusion and conversion to laboratory. Confirm blood group and cross-match. Availability for higher risk cases. Ensure adequate exposure. Most important, the positioning, the retraction, the lighting, and the trained assistant. So what should be the technique? Core principles of the pedicle control. Number one is clamp under the direct vision. Never clamp blindly across the tissue, which you cannot see fully. Number two, take an adequate tissue bite. Too small risk spillage and too large risk ureteric injuries. Number third is cut close to the clamp. Leave enough pedicle stump for the secure, reliable ligature. And fourth is ligate or transfix before releasing the traction that confirms the hemostasis before moving to the next pedicle. The safest hemostasis is one prevented by correct technique. Then operative sequence, sequential pedicle ligation, then working order, uterosacral cardinal ligaments, clamp, cut, transfix, often tagged for lateral wall support. Uterine vessels, double clamp, secure the transfixion suture, highest risk pedicle. Broad ligament and nexal pedicel, utero-ovarian or the 𝗕𝗏𝗏𝗏𝗏𝗏 pedicle secured under region. Re-inspect all pedicles, confirm hemostasis on every pedicle before vault closure. Skipping a stepwise hemostasis check is the most common cause of missed bleeding. So early recognition, recognizing bleeding early, arterial bleeding, bright red, pulsatile, spurting flow. Rapid pooling despite the continuous sponging, often accompanied by tachycardia. Venous or the diffuse ooze, darker, steady, non-pulsatile flow, often from the broad ligament or raw peritoneal surfaces. Easy to underestimate visually. Communicate estimated blood loss with anesthesia and continuously. Visual estimates alone tend to underestimate the true loss. Be careful about it. Now, what should be the first response? Immediate response algorithm is stop and call for the help or extra hands if bleeding is significant. Apply firm direct pressure with a sponge or a pad. Do not clamp blindly. Third is improve exposure. Improve exposure, reposition, better retraction, suction, and adequate light. Fourth is identify the exact bleeding point before attempting a definitive control. And fifth is communicate blood loss, vitals continuously with the anesthesia team. Now, definitive control, manage uterine artery or the pedicle bleeding, reclamp under direct vision, incorporate the full pedicle in a single well-placed bite, place a secure transfixion suture, figure of 8, delayed observable material, place proximal to the bleeding point. If the vessel has retracted, apply pressure first, clear the thin exposure before suturing, never suture blindly near the ureter. Consider a vessel sealing energy device shown to reduce the blood loss 47% in compared to the suture ligation alone. So, beyond the pedicle, broad ligament and retroperitoneal walled bleeding, walled and vaginal artery, that's the lateral fornix, clamp and ligate the bleeding to the point directly, delayed absorbable transfixion suture through mucosa, paravaginal tissue, and a broad ligament retroperitoneal, suspect if the hematoma expands with no visible vaginal source. Apply pressure, open the peritoneum to visualize if needed. Avoid blind clamping near the ureter or the pelvic vessels. So the adjoint therapies which we can do with the hemostatic techniques, first is electrocoagulation, bipolar monopolar current to diffuse surface oozing, topical hemostatic agent, oxidized cellulose, gelatin, thrombin matrix over the bar surfaces, tranexamic acid for the refractory diffuse bleeding unresponsive to local measures, vaginal packing, tamponade when discrete source cannot be isolated, vessel sealing devices, energy-based sealing for reliable rapid pilot control, and reinforcing sutures, a second transfixion layer over an oozing but non-arterial pedicle. So the decision points when to escalate: hemodynamically, instability despite initial measures, activate the massive transfusion protocol without delay, bleeding source not visualized or controlled vaginally, convert to laparoscopy or laparotomy for direct access, retroperitoneal or a pelvic side wall bleeding, consider interventional radiology immobilization, clinical success up to 90%, complication rate 10%. Any uncertainty involves senior colleague or other colleagues early for the help. Do not delay escalation. So vaginal hemostasis, check and vault closure before you close. Systemically, reinspect every pedicle, uterosacral, uterine, broad ligament, and nexus. Ask anesthesia team to transiently raise the blood pressure to unmask the unhopeful bleeders. Ensure vault closure incorporates all the pedicle without tapping an active vessel. Consider a vaginal pack or a drain if oozing persists despite of the visible hemostasis. Document the estimate blood loss, technique used, and any transfusion given. So the summary and the key takeaways: most bleedings in the vaginal hysterectomy is preventable with correct pedicle technique, not rescued after the fact. Know your patient's risk factors before you cut, before you start. Identify before you clamp, never clamp blind. Follow a clear escalation: bladder pressure, suture, energy device, laparotomy, and embolization. This should be the sequences. And when in doubt, call for help as early as possible.